Hello everyone, and welcome back to my channel. My name is Dr. Stephen Roth, and I'm a board-certified oral and maxillofacial pathologist. And today we'll be going over another essential differential. This topic is the non-healing ulcer. But first, we gotta go over that disclaimer, and that is that all of the opinions expressed in this video are mine and mine alone, and do not represent any organization that employs me or any professional organization to which I belong. In addition, this video is meant for educational purposes only and should not be taken as medical advice. Should you have any questions about your oral health, please see your nearest oral healthcare provider. And with that being said, let's get into today's topic. So the key to this differential is that we're talking about non-healing ulcers. A good benchmark is around 2 weeks. So if an ulcer has been present for about 2 weeks, you're going to want to apply this differential. However, if an ulcer goes away within that 2-week time span, then there are a vast variety of different processes that can cause ulceration of the oral cavity. The oral cavity mucosa takes approximately 2 weeks to regenerate, so that's why this is a really good rule of thumb. The other key here as well is that it's one focal ulceration. If there are multifocal ulcerations or a diffuse erosive process, then this differential doesn't apply, and it may be something along the inflammatory or systemic or vesiculo-erosive differential. But this is specifically a non-healing ulcer that is solitary and that hasn't healed within 2 weeks. So there are 4 things that I like to keep at the top of my differential. The first one is a traumatic ulcer. Now, in the oral path world, we like to refer to this as a TUGSE, T-U-G-S-E. And that is an acronym for traumatic ulcerative granuloma with stromal eosinophilia. But because it's not really a granuloma, I like to modify this a little bit and call it traumatic ulceration with granulation tissue and stromal eosinophilia, which is more what it looks like under the microscope. This case is an example that I've seen from my own practice of a TUGSE, and it is a non-healing ulcer, and you can clearly see in this picture a right mandibular first molar with a very sharp cusp. That sharp cusp is causing this really large ulceration with that rolled border and the blending leukoplakia around the outside. This case is most likely traumatic in origin, but you can't always judge a book by its cover. When we take a biopsy of this lesion and we look at it under the microscope, the name is really helpful because we see this granulation tissue as well as some eosinophiles, which if you watched my video on histopathology basics, you know that eosinophilic means red. So eosinophiles are inflammatory cells that appear red. The nice thing about these TUGSEs is that biopsy is often curative. So as long as you remove the offending source that might be causing it, and that could be a sharp cusp tip, that could be a removable prosthesis like a partial denture, that could be a perifunctional habit, it could be braces, it could be a wide variety of things. But the biopsy and the primary closure with sutures can actually lead to healing. So the biopsy in and of itself may be curative for these patients. There are rare examples where sometimes the biopsy doesn't resolve the issue, and in fact, this patient, although this lesion looks very, very scary, is just a TUGSE. This patient has had 2 skin grafts on the tongue to try to help close this ulcer, but for some reason the granulation tissue becomes so proliferative that it just hasn't healed. And this is a very difficult circumstance to treat. So traumatic ulcer is the first in our differential. The next is squamous cell carcinoma. Now, squamous cell carcinoma is far and away the most common malignancy or cancer that we see in the oral cavity. So a non-healing ulcer that lasts more than 2 weeks in the oral cavity should be biopsied to rule out a squamous cell carcinoma. This is a very interesting case that I came across. This patient reported to the emergency department, and we did a biopsy of this lesion. You'll notice that this is very similar to the last case that I showed, and that there's an ulcer with a rolled border with blended keratosis or blended white around the outside. Looking at the panoramic radiograph, you can appreciate there was also a broken down tooth that actually fit right in the center of this ulcer. So my leading differential was traumatic ulcer versus squamous cell carcinoma, because those were the two most common. This patient had had that ulcer for, I believe, if I remember correctly, around 8 months. So that was a long time to have an ulcer that hasn't healed. And unfortunately, on biopsy, we did see a moderate to poorly differentiated squamous cell carcinoma, which obviously requires significantly more treatment, such as surgical removal, potentially a neck dissection, where the lymph nodes are examined and removed, and potentially chemotherapy and radiation, which I do believe that this patient underwent. So the last two in this differential are admittedly more rare, but definitely worth mentioning. And in fact, there have been times where I've had patients where I was convinced that they had a squamous cell carcinoma, a cancer, or it was caused from trauma. And on biopsy, it was one of these two very rare things. And I plan to make both of these instances some crazy case files, so be sure you subscribe so you don't miss those videos in the future when I go over me encountering these in the wild. So the first of the more rare, but still belongs on the differential, is a deep or specific fungal infection. Now, this isn't your run-of-the-mill Candida, which is the species that causes most fungal infections in the mouth, or yeast infections, or sometimes called thrush, colloquially. These are specific fungal organisms that usually do not infect the oral cavity. They, in immune competent people, meaning people with a full immune system, often go into the lungs and either cause little flu-like symptoms or cause no issue. So what are these specific fungal organisms? It kind of depends on where you live. In the Ohio and Mississippi River valleys, which is actually where I'm from, the most common of these organisms is histoplasmosis. And this case is provided by a colleague of mine, Dr. Indranil Bhattacharya from the University of Florida, who was very gracious enough to allow me to use this case of histoplasmosis on the tongue that presented as a non-healing ulcer. Another fungal organism is blastomycosis. Blastomycosis has a lot of overlap with histoplasmosis in that it occupies the central United States and Mississippi River Valley, and so it's a little bit more widely seen geographically. And then finally, coccidiomycosis, which is primarily found in more arid climates like the Southwest United States and Mexico. Now, while these are fungal infections, you gotta admit that that picture is a little concerning, and you might actually think about a squamous cell carcinoma based on maybe some other pictures that you've seen of cancer. And that certainly has been the case for me when I've seen cases like this in practice, where I was a little concerned about cancer and saw the microorganisms on biopsy. These specific fungal infections require different types of treatment based on the classification. So based on what we see under the microscope, we can probably determine what organism it is, but we can also culture as well to get a more definitive answer. And sometimes we add different things like PCR, polymerase chain reaction, to genetically figure out what organism is affecting the patient. And the last is also rare, and that is tuberculosis. Now, tuberculosis is more commonly seen on the gingiva if it's seen in the oral cavity at all. And I will say that TB in the oral cavity is pretty rare, especially in developed nations, but it can be seen and it can present as a non-healing ulcer. But after the gingiva, a non-healing ulcer on the gingiva, it can appear on the tongue. That's the second most common place. There are a few different theories as to why these ulcers are created by these microorganisms, the tuberculosis organisms. One is direct inoculation. TB is primarily a condition of the lungs, and so the thought is if these patients are coughing up TB organisms, it can be embedded into the oral cavity, into the oral tissues, and create these ulcerative lesions. The other theory is that the TB is hematogenously spread, meaning it goes through the bloodstream to the oral cavity, and that's how it affects the tissues. We don't really know for sure, but we do know that when we look at these under the microscope, that we can actually potentially see these organisms. I will say that identifying TB can be a little bit difficult. We use a special stain called AFB, acid fast bacilli. And that does help highlight them, but these are so small and can be difficult to see on biopsy. So a lot of times we have to do blood tests and a lot of other tests to get to that definitive diagnosis. Just like the specific fungal infections, you can appreciate that in this case, it does look a little bit worrisome, and maybe you might be thinking about cancer when you look at it. So there you have it. The differential for the non-healing ulcer in the oral cavity: trauma, squamous cell carcinoma, deep or specific fungal infection, and tuberculosis. I hope that you found this video helpful. If you did, please give it a like and share it with someone else that may find it helpful as well. Don't forget to subscribe so you don't miss any of my future videos. And with that, take care and be well.